Hello, everybody. This is Dr. Ashur. Today, we are going to start a new series of videos where we talk about the pharmacologic treatment of heart failure. This series will include three parts. Part number one will be the pathophysiology of heart failure. Part number two will be drugs in heart failure. And the part three we will talk about inotropic agents in heart failure. We will start right now talking about pathophysiology of heart failure. Now we are going to talk about the first part, which is the pathophysiology of heart failure, which will include two videos. The very first video, through which we will talk about the heart failure, what it is, its etiology, prognosis, and epidemiology. We'll talk about some cardiovascular physiology facts, and then identify the most important clinical features of heart failure. We'll talk about the signs and symptoms of heart failure. Heart failure, what's heart failure? It's a complex progressive clinical syndrome in which the heart is unable to pump sufficient blood. The heart can pump blood, but not sufficient to meet the metabolic demands of the tissues of oxygen and nutrients as a result of impaired cardiac function. So the story starts from here, impaired cardiac function. So now the heart cannot pump enough blood to meet the demands of the tissues of oxygen and nutrients. It's typically associated with, number one, reduced functional capacity of the heart to pump blood. If the heart's unable to pump blood, what would happen as a consequence? It will be a congestion, pulmonary and systemic venous congestion, as we will explain later. Okay, it's a primary direct cause. Its primary direct cause is the impairment of the heart. The primary direct cause of heart failure is, number one, the heart cannot fill, which is called diastolic heart failure. Or the heart cannot empty, cannot push the blood to the tissues, which is called systolic heart failure, which will be explained in the next video, not this video. The causes include coronary artery disease, hypertension, uncontrolled hypertension, myocardial infarction, and valvular heart disease. It's a major contributor to morbidity and mortality worldwide. It's a leading cause of hospitalization in people older than age 95. It's a highly lethal condition. The 5-year mortality rate is about 50%, which means that if we count the death from the day the patient is diagnosed with heart failure until within 5 years, these patients, suppose we are talking about 1 million patients, so half of these patients are usually they die, these 50% of these patients. However, if the case is very advanced, the patient, about 50% of the patients die within 1 year, within one single year. Why the number of the heart failure patients is increasing? Because actually, as we said, myocardial infarction and other causes. So these causes are being dealt with much more properly as compared to decades before. So now the patients could live longer, and if they survive these disasters of myocardial infarction and other, they are expected to suffer more from heart failure. Generally speaking, the number one leading cause of death is cardiovascular disease. Look here, this is the global cause of death. Number one is ischemic heart disease followed by stroke. If we talk about leading cause of death worldwide, heart disease number one. In Malaysia, where we're talking to you now, it's also ischemic heart disease is the principal cause of death. Okay. What about the gender, male and female? Usually males are more susceptible to develop heart failure than females until the very old age, where the female can develop heart failure more than males, and we will explain this later. The heart failure is expected to triple. So the number, if it is 1 million, okay, or one-fold, we are talking about threefold increase in heart failure within until 2060. So within about 40 years, the number is projected to triple. This indicates this is a very dangerous disease that we need to deal with in the best manner. Okay, now we agreed to recall some cardiovascular physiology facts. So in the beginning, let me remind you the heart collects blood from all tissues through the inferior vena cava and superior vena cava to the right atrium, which pushes the blood to the right ventricle, and then the right ventricle will push the blood to through the pulmonary arteries to the lung, and the blood will be oxygenated in the lung and comes back through the pulmonary veins, okay, pulmonary veins to the left atrium. Left atrium will push the blood to the left ventricle, and through the aorta it will push the blood to all body tissues, including the heart itself. This is just a collective photo showing the circulation again. Blood comes through the right atrium, right ventricle to the lung, oxygenation, back to the pulmonary veins, left atrium, left ventricle, then through the aorta to the whole body, including the heart itself. Okay, when you talk about the heart, the arterial blood pressure. When we talked about heart failure, we said one of the principal causes of heart failure was the hypertension. Hypertension is elevated blood pressure. What's blood pressure? Arterial blood pressure equals cardiac output times peripheral resistance. So the body need to pump blood at sufficient rate to maintain adequate and continuous supply of oxygen, nutrients to body organs. Okay, so each time the heart beats, a volume of blood is ejected. So the amount of blood that pumped by the ventricles, each beat is called stroke volume. So each systole, okay, this is called stroke volume. Okay. If we multiply the stroke volume times the heart rate, which is the beats per minute, this will be called the cardiac output. So cardiac output equals stroke volume times heart rate. Stroke volume, the unit is milli per beat, and heart rate, the unit is beats per minute. If you take the numerator with the denominator here, they will cancel to the final unit of the cardiac output is milli per minute. Again, the cardiac output is the blood, the volume of blood that's pumped by the heart per minute. Stroke is the same thing, but it's per beat. Cardiac output is per minute. Okay? Okay. Then the second player, we said here, the blood pressure equals cardiac output times peripheral resistance, right? So peripheral resistance refers to the resistance blood flow offered by the systemic vasculature. Anything that increases vasoconstriction, that like activation of alpha receptors by adrenaline or sympathetic nervous system, will cause vasoconstriction, which will increase peripheral resistance. Easy, right? Mechanisms that cause vasodilation, like activation of beta-2 receptors in the blood vessels by sympathetic nervous system, will cause vasodilation, which will decrease peripheral resistance. Normal healthy heart with the normal cardiac output pumps usually between 4 to 6 liters of blood every minute, okay, when the person is resting, no exercise, okay. So the stroke volume usually is 70 mil per beat, and the heart rate is 70 beats per minute. Multiply this by this, it will bring you up to about 5 liters per minute. Okay. However, during exercise, the cardiac output expands like 3 to 5 times. So instead of 5 liters per minute, it goes to about like 10 or 15 liters per minute, maybe 20 liters per minute. Okay, why the heart is not using that? Because not needed. It is not needed at that time during the rest, but use it only during the exercise. That's why it's called cardiac reserve. So it's just a reserve. I use it when I need it. Regarding the changes of cardiac output with age, the baseline cardiac output remains relatively unchanged with age. However, the ability to expand the exercising cardiac output volume, which is called the cardiac reserve, decline with age. In heart failure, usually cardiac output is below the normal range of 5 or 4 to 6 liters per minute. So this results from decline in the stroke volume. So now the pumping capacity of the heart decreases. So now the stroke volume decreases due to systolic dysfunction, diastolic dysfunction, or a combination of both. Before the heart contraction, the heart fills with blood. Okay, so right before systole, right before contraction, so the heart fills with blood. This filling volume is called end diastolic volume. The name speaks about itself, right? End diastolic volume. So at the end of the diastole, the heart will fill with blood, ready for the systole. Okay, and it's approximately 120 milliliters. This stroke, end diastolic volume, I'm sorry. Following filling, so now it's filling, now it's end diastolic volume ends. Now we are starting contraction. Okay, the heart contraction, so systole starts, and the heart ejects most of the blood, usually about 60%. So the end diastolic volume minus stroke volume is about 70. End diastolic volume is 120 here, right? There is a residual volume is called end systolic volume, because this volume remains after the heart pumps, okay? Which indicates that the pumping heart is never drained entirely from blood. The end diastolic volume, just if you try to count again, it's 120 because it contains stroke volume 70 and end systolic volume 50, total will be 120. Finally, the ejection fraction, very important. When we talk about heart failure, we'll talk about the ejection fraction, whether it's changed or not or whatever. This we'll talk about in the next video. It's a fraction of blood ejected by the ventricle relative to the end diastolic volume. So now the end diastolic volume is 120. How much is pumped out of these 120 is the ejection fraction. So the ejection fraction is stroke volume divided by the end diastolic volume times 100. So 70 divided by 120 times 100 is equal about 60%. So within, if the ejection fraction is about 40 to 60% is normal in normal persons. Okay, so during exercise and highly conditioned like athletes and individuals, okay, the stroke volume increase and can result in ejection fraction exceeding even 90%. But this is during exercise. However, in heart failure, the stroke volume decreases and the ejection fraction can decrease to maybe 20% or even less. Okay, now we are done with the cardiovascular physiology. Now the clinical features of heart failure. As we said, the heart cannot pump blood, so there is some stagnation there, right? So everything, okay, that's coming after that point will have traffic jam, okay? So this is in cardiovascular system called congestion. So look here, like this is the normal traffic, okay? So there is a big distance between each car and the next car. However, if there is some demonstration or anything happening that stops the flow of the cars, like the heart cannot pump blood, okay, cannot pump blood efficiently, so now there is stagnation here. So these cars will be traffic jam here, not only here, but even very long traffic jam. This is what happened. That's why we have in the patient with heart failure, pulmonary congestion, peripheral congestion, elevated jugular pressure, so many things related to congestion. Okay, so now clinical features includes signs and symptoms. Okay, symptoms include number one, peripheral edema. Okay, like ankle and foot swelling. Okay, and see swelling specifically in the ankle because it's of the gravity, the blood cannot go up. Okay, because there is a stagnation of the blood in these, easy stagnation of blood in these extremities due to systemic venous congestion. As I said, the heart cannot pump blood, so everything coming before this point and even before this point will have congestion. Anorexia, okay, because there is a peripheral edema, swollen or tender abdomen, so the patient does not need to eat, doesn't like to eat, so loss of appetite. Orthopnea, when you ask the patient to lie down, lie flat on the bed, the patient will have dyspnea, will have difficulty in breathing. So why? Because there is a fluid distribution to the central circulation, so the blood is around the heart and the lung. Okay, so there will be increase in pulmonary capillary pressure and pulmonary edema. You see here the previous photos, I think, help a little bit. Dyspnea on exertion or shortness of breath on exertion and even at rest, again due to pulmonary edema. Okay, remember now the pulmonary arteries bring the blood from the lung to the heart, right? If there is some stagnation in the heart, there will be congestion in the lung. Paroxysmal nocturnal dyspnea at night. So again, the fluid distribution and renal reabsorption, pulmonary capillary pressure will increase, and pulmonary edema will be the resulting issue. Nocturnal cough, again due to pulmonary edema. Sorry. Reduced exercise tolerance with rapid fatigue. The normal person, when you exercise, no problem. But these patients, if you remember, when we talk about the cardiac reserve, okay, these patients cannot increase the cardiac output 3 to 5 times, if you remember. So that's why they have this reduced exercise tolerance, okay, due to decreased cardiac output and also pulmonary congestion. There is no good exchange of gases, okay. So it's the major direct consequence of the diminished cardiac output. Signs includes cardiomegaly, okay, the heart size will increase due to enlargement of left ventricle, right ventricle, or both chambers, or even other chambers. Displaced apex speed. In our PBL and case discussion, we usually talk about apex speed. Okay, the normal apex speed should be in the 5th intercostal space in the mid-clavicular line. Okay, in the mid-clavicular line. If it is displaced, can I say 100% this is cardiomegaly or heart failure? I say just wait, please. Check the tracheal position. If it's also shifted, this means that the apex speed is placed because of the enlargement of the lung itself. So lung fibrosis, collapse, or pneumothorax. However, if it is the trachea still central, but there is the apex speed is displaced from the 5th intercostal space and mid-clavicular line, so now we can say cardiomegaly. There is enlargement of the left ventricle, right ventricle, other chamber. Sorry. Then tachycardia as a compensatory mechanism. So because now there is less blood that's reaching the circulation, so now there will be activation of the sympathetic nervous system, increase in the heart rate, as we'll discuss in the next video. Right ventricular heave or left parasternal heave, both are the same thing. It's precordial impulse. Precordial means when you palpate the area above, on the thorax above the heart, is called precordial impulse. That can be palpated. Usually you cannot palpate the heart, but because the heart is undergoing hypertrophy, the size of the heart is getting bigger, so it can pump into the thorax. Okay, so you can feel it when you palpate the heart. Signs. We know the two heart sounds, the first and second heart sound. These are the normal heart sounds that result from closure of the mitral tricuspid, and then the second one is due to closure of the pulmonary and aortic valves. However, in the patient with heart failure, there is a third heart sound. Okay, third heart sound. Okay, this is due to the rapid high volume filling of the left ventricle. Okay, it's found in left ventricular heart failure. Elevated jugular venous pressure, again due to systemic venous congestion. Pulmonary crepitation or wheeze due to pulmonary edema. Hepatomegaly due to systemic venous congestion. All of these are coming because there is some stagnation, there is some traffic jam in the heart level, so everything will have congestion. Ascites, fluid accumulation in the abdominal cavity due to systemic venous congestion. Cachexia and muscle wasting due to loss of appetite. We said there is there is congestion on the level of the abdomen and the liver and everywhere. So there will be loss of appetite, and also there will be raised plasma levels of epinephrine, cortisol, aldosterone. All of these will be associated with cachexia and muscle wasting. Collectively, the clinical features can be summarized as shortness of breath, again due to the pulmonary congestion, cough due to pulmonary congestion, swelling of feet and legs, swelling, tender abdomen with loss of appetite, these due to peripheral edema, chronic lack of energy to do that because now the heart cannot pump enough blood to the tissues, increased urination at night because of the central redistribution to the central circulation at night. So there will be increase in urination, difficulty in sleeping due to breathing problems due to pulmonary congestion, and in advanced cases, advanced heart failure cases, there will be less perfusion of the brain or brain perfusion, which can cause confusion and impaired memory. Okay, we are done with this part, and I'll see you in the next part pretty soon. See you. Bye.